Student learning outcomes are straightforward. I'm not going to go through them all. Inflammation is an immunologic defense against tissue injury, infection, or allergy. It's the body's reaction to an injury, irritation, or infection. The scope of the concept is simply no inflammation versus active inflammation. It can be acute, chronic, or restorative. It can also be localized or systemic. Risk factors are people who are at risk. As you age, you have higher risk for infections and inflammation. Genetics can play a role. Poor hand hygiene in the poor and underdeserved areas of the world. We'll talk more about with hepatitis and how that comes into play. Also, alcohol use disorder over time can cause inflammation of the liver, and chronic and viral hepatitis, and then underlying medical conditions can also apply. So physiologic processes and consequences. So an overly severe immune response to stimuli could result in additional tissue damage or inadequate response, leading further to infection or chronic inflammation or damage, which we'll talk about with cirrhosis. So assessment of patients for inflammation, you always want to be thinking of swelling, erythema, pain. They may have fatigue, how long they've been having their symptoms when they started, and if they're currently undergoing any sort of treatments, whether it be self-treatment at home or if they're seeing their physician being treated for something. Exam findings are pretty straightforward. I mentioned a few of the common ones, but if some infection or inflammation is not treated, it can progress to shock or multi-organ failure. And then diagnostic tests, in this case talking about cirrhosis and hepatitis, we look a lot at the liver enzymes, LFTs, also do radiographic tests, ultrasounds, and liver biopsy as well, which we'll talk more about.
Kim, would the BMI be high or low? High.
It could be high, yeah, if they're overweight. They're at higher risk for inflammation, infection. So lab values that you guys should be familiar with, and Clicks really likes lab values. So for the liver enzymes, the ALT, AST, and ALP are all important and indicative of some sort of inflammation or damage to the liver. And then also bilirubin, we'll talk a little bit about too when we're looking at patients with liver disease and having jaundice. Their bilirubin levels will be elevated. Albumin levels, the normal is there, but typically they will be low in patients who have liver disease, especially if they have ascites. And ammonia levels come into play with their importance in patients who are exhibiting hepatic encephalopathy, and we'll talk about that as well. Some other labs that are not on this chart that I'd like you to jot down would be your coagulation labs. So that would be like your PT, prothrombin time, your PTT, which is your partial prothrombin time, INR, and your platelets. Does anybody know what a normal PT would be?
11, 14 seconds.
Yep, so 12 to 16, in that range, yes. And then PTT? Yep, 60 to 70. And then your INR go around 1. And what are normal platelet ranges?
50,000 to 400,000.
Yep, so 150 to 450,000. Yep. So patients who have liver disease, their liver is not making enough clotting factors, so that's why we may see that their clotting factors are off and they're at higher risk for bleeding. So with those sort of patients, you will instruct them to avoid injury, specifically head injury. If they bump their head, let their physician know. Also, even just as simple as telling them to use a softer toothbrush so that they don't damage their gums and cause more bleeding, that sort of thing. Clinical management of these patients, so primary prevention would be appropriate hand hygiene, food and water safety we'll talk more about with hepatitis. Also using safety equipment for risk of falls, and safety risks for patients who may be encephalopathic or at risk for falls. Secondary prevention is the screening, which would be their lab work that we discussed. Collaborative interventions would be treating the underlying cause and carefully monitoring to prevent or slow the progression of the disease. Because if someone is developing cirrhosis, whatever damage is done to the liver is final. There's no irreversible process that can happen with cirrhosis. So once it happens, it's permanent damage. So to talk more about cirrhosis, it's the chronic disease characterized by extensive irreversible scarring of the liver. So the liver tends to become very fibrinous, and it's an overgrowth of the tissue that typically in the beginning, you'll see under manifestations says liver enlargement, when it may be in the beginning stages, but over time as cirrhosis advances and someone becomes more end stage, their liver is actually going to be shrunken and really hard because of all the scar tissue that has formed. So all of that scarring is irreversible. With these changes that happen within the liver, they put a higher pressure for the blood to perfuse, so there's an increased resistance in the portal venous system. Because a lot of the vessels are trying to recreate pathways when all this scarring is forming, and it's not as easy for the liver to perfuse their blood. Contributing factors, so alcohol abuse is a common factor for cirrhosis, but it typically takes someone an average of heavy drinking for greater than 5 years to end up with cirrhosis. So it doesn't happen right away, it's more of a chronic use of alcohol. Post-necrotic would be when someone has had hepatitis, more commonly hepatitis C, can lead to chronic liver damage and cirrhosis as well. And biliary disease, if someone has bile ducts that are clogged up, or if there is inability for the gallbladder to empty, that can also cause cirrhosis, but that is a less common cause. And then as we know with severe right-sided heart failure, patients can develop liver damage and cirrhosis. So labs, again, we discussed liver enzymes are important, most likely going to be elevated in these patients, and also monitoring their albumin levels, which would most likely be low, ammonia levels because of the risk of hepatic encephalopathy, and bilirubin levels may be elevated and cause jaundice, and also their cholesterol levels. For scopes and studies with cirrhosis, endoscopy is a very common procedure that patients will undergo, and patients who have cirrhosis typically undergo an EGD or endoscopy of the upper esophagus, the stomach, and the duodenum every 2 years or so to just assess if there are any complications and progression of the disease. And then another scope and study would be endoscopic retrograde cholangiopancreatography. So that parentheses next to it should really say ERCP instead of EGD there. and we'll talk a little bit more about that, but that looks at the biliary ducts. And then liver biopsy is really used to confirm that a patient has cirrhosis. It can also help to determine the cause. And manifestations, so liver enlargement, I mentioned originally in the beginning stages, they may have an enlarged liver because it's inflamed, but over time as they progress, if they do progress to end stage, their liver is going to be hard, nodular, full of scar tissue, and shrunken. They may also have some portal obstruction because of portal hypertension, which we'll talk about, ascites, which is a fluid accumulation in the stomach, in the abdominal cavity. They may develop varices, esophageal varices, which are very important, high-risk complication we'll discuss more about. And also, they may have some vitamin deficiency, so these patients will be on vitamin B, thiamine, folic acid, ensuring that they are receiving the nutrition that they need. And petechiae is also common in these patients simply because of the coagulopathy that I had discussed. When their coagulation factors are abnormal, they're at higher risk for bleeding. So petechiae may be found in these patients. Asteristics is the flapping of the hand and wrist in patients who are encephalopathic, which I'll talk more about when we get to that slide, and also mental deterioration once someone does have hepatic encephalopathy. Their LOC is decreased and eventually could lead to coma, so that's also a major complication. Patients with cirrhosis, oh yeah.
Is that what they call, like, rot brain? Do you know what I'm talking about?
Rat brain?
Someone that's, like a constant, like, alcoholic.
Squash brain?
Squash brain, that's what it is.
Oh, I haven't heard of that
I think it's
term.
wet brain. I've heard that one. Which one?
Brain.
Wet brain, like wet brain. I've heard squash and rot brain.
I haven't
It's
heard of
terrible
those.
names.
I
Like,
haven't
you know,
heard of those.
alcohol for alcoholics at a certain point, that's what I thought, that, you know, by mental deterioration.
Oh, so that would be like hepatic encephalopathy, yes. And then patients who have cirrhosis are at risk for developing liver cancer. And they also are at risk for developing infection and sepsis as well. Because when bacteria is leaking into the peritoneal cavity, then they are at risk for a complication called spontaneous bacterial peritonitis, or SBT. So that's something you should be aware of as a potential complication. And does that,
You said bacterial what?
so spontaneous bacterial peritonitis, SBP. Does anybody know what some signs and symptoms of developing bacterial peritonitis would be?
I would guess like fever,
Yep, fever,
rigid habit.
rigid abdomen, yep, so that's a classic symptom, and abdominal pain. So those are the three classics.
So cirrhosis is not progressive if the underlying cause is corrected, or it is?
Yes, so.
It's just
it-
irreversible.
Yes,
Okay.
whatever damage has been done cannot be
Okay.
reversed. But it is, you can slow the progression
Okay.
and, you know, if you were to, say, if it was caused by alcohol and you were to rid of that causative factor,
Okay.
then you could slow the progression of it.
So if someone has like a lot of ascites,
Mhm.
like already they're gonna have like asthma pain, obviously.
Mhm.
Would they have-
So nursing care for these patients, their respiratory status should be monitored closely, especially if it is someone who has a lot of ascites, because their very large abdomen that's full of fluid will be pressing up on their diaphragm, so they may not be able to breathe effectively. Positioning these patients would either be like a semi-Fowler's or high Fowler's if they're in distress. As a rule of thumb, I like to keep in the back of my mind 30 degrees with the head of the bed, so it can help the expansion of their lungs. Also skin integrity, especially if you have a encephalopathic patient who is bedridden and unable to really communicate if their pressure points are becoming sore and unable to turn themselves. So these patients would have to be turn repositioned every 2 hours, elevate the heels, cushion bony prominences. They should have a skincare bundle in place. And patients will sometimes have pruritus or itchy skin. And if they do have that, the recommendation would be to wash with cold water and no soap, and to apply lotion to help with the itchiness. Because the warm water and hot water tends to dry out your skin even more and cause more irritation. So that's why they recommend the cold. Monitoring their fluid balance is also important, monitoring for fluid volume excess, following their INOs very closely, especially if they're on diuretics, monitoring their ascites if they do have it. We'll talk more about that, but measuring the abdominal girth of the patients, assessing for edema. And a lot of patients will have some fluid restriction and sodium restrictions as well with their diets. Vital signs, pretty straightforward, just monitoring their vital signs, monitoring if they have any discomfort or pain. Neurological status, monitoring for signs and symptoms of hepatic encephalopathy, which would be a decreased LOC. We'll talk more about that when the ammonia levels are rising. And nutritional status, these patients do best with high carb, high protein diets unless they're at risk for hepatic encephalopathy, because proteins will break down into ammonia. Oh yeah, did you have a question?
Yeah, for these studies, could you just use, like, to get rid of it, would you just use Lasix, or would you go in and drain it?
So they typically use spironolactone, the potassium-sparing diuretic,
Okay.
and then if it is severe enough, they oftentimes will do a paracentesis to relieve the pressure, more of a therapeutic treatment.
So it's like individual kind of?
Yes.
Okay.
So back to nutritional status. So protein breaks down into ammonia. So patients who are at risk for hepatic encephalopathy are oftentimes limited or restricted with their protein intake. Moderate fat and low sodium, and also the vitamin supplements that I mentioned earlier, thiamine, folate, vitamin B, multivitamins. GI status, monitoring for any increase in their ascites by measuring the girth, observing for any potential bleeding. They're at high risk for bleeding, especially if they have esophageal varices. And patients too who are receiving treatment for hepatic encephalopathy will be on lactulose. So part of the GI assessment is monitoring their bowel movements, because if someone is on lactulose, they're going to have more frequent bowel movements, because that's how the ammonia is excreted. And if it's loose stools, we want to be able to communicate that to the physician or provider. And then pain status, again, pretty straightforward, assessing their pain and comfort, and also just providing emotional support and family support for these patients. So talking a little bit more about the procedures that were mentioned, an EGD, so that's the endoscopy of the esophagus, stomach, and the duodenum. Patients are typically NPO 6 to 8 hours prior to the procedure, and they're also asked to avoid any anticoagulants, aspirin, NSAIDs, because they are at risk for bleeding. IV sedation is typically given for comfort during these procedures. The common medications given would be midazolam, or Versed is the other name for that, and also fentanyl for a little bit of pain control. Atropine is sometimes given if the patient has a lot of secretions. It can be given to dry up the secretions. So you've heard of atropine in previous classes for bradycardia. Well, in this instance, it's used in a different instance to dry up secretions. Sometimes they may receive local anesthetic spray to the back of their throat, just simply for comfort, because of the scope going down their throat can be really uncomfortable and cause them to gag. And preventing aspiration is also important. Patients are often placed on their left side to help clear the secretions and promote drainage of their pulmonary secretions. And then monitoring for perforation. So anytime that some sort of instrument is introduced into the body or into the intestine, there is risk of perforation, especially because they put a lot of air into the stomach and intestines during these procedures too. So monitoring a patient after an EGD for increased pain, or if they're having hematemesis or bloody vomit, and also development of fever. Those would be your symptoms of perforation. And then just providing comfort measures for them because they'll oftentimes have a sore throat afterwards. You also want to maintain their safety. Oftentimes they are on strict bed rest after receiving the sedation until they're back to baseline. And then for an ERCP, so this test examines the liver, the gallbladder, the bile ducts, the pancreas, and they use x-rays to look at, if there's any obstruction or if there's any, gallbladder sludge. They can see all of that in an ERCP. So again, NPO, 6 to 8 hours, avoiding anticoagulants because of the risk of perforation and bleeding. Sedation would be the same, something to help relax them, which would be the midazolam or Versed, and something for pain, oftentimes is fentanyl. And it is common after an ERCP to have just a colicky abdominal discomfort, not so much severe abdominal pain, but it might feel a little bit crampy and colicky. And because this procedure does involve x-rays and looking at the flow through ducts and everything, we have to assess if they have any allergies to x-ray dye as well. And then a liver biopsy. So patients are NPO a little bit longer for this, 8 to 10 hours. Informed consent must be obtained prior to, because there is high risk of bleeding. The liver is vascular, and if their liver is malfunctioning, and that's why they're having this test, then their coagulation could be abnormal as well. So it puts them at even higher risk for bleeding. So assessing their coag studies, which would be your PT, PTT, and INR. And then positioning on the affected side. So after a liver biopsy, you typically keep them on their right side to kind of promote homeostasis where the needle has entered. And again, just monitoring for bleeding complications, as mentioned before. So complications of cirrhosis. Jaundice is pretty straightforward, where it's the yellowing of the sclera and skin due to an increase in bilirubin levels. And the bilirubin levels generally have to reach 2.5 or higher to start to see any jaundice on the skin or sclera. And it's because of the flow of bile is obstructed, and there could also be excessive destruction of red blood cells as well that's causing this increase in bilirubin. Hepatic encephalopathy. So this can be life-threatening if it is not treated. We'll talk more in depth about it on the next slide, but basically it is an accumulation of ammonia, which is toxic in the blood. So it causes a lot of mental status changes and puts people at high risk for developing a coma if it is not treated. Portal hypertension, so this is when the blood flow is obstructed in the liver, and that puts an increased pressure on the portal venous system. And portal hypertension will lead to ascites and the development of esophageal varices as well. Ascites is the accumulation of fluid within the peritoneal cavity. Is the decreased synthesis of albumin, decreasing serum osmotic pressure. So because of all the fluid shifts, the abdomen fills up with fluid. And again, we'll talk more about that with a specific slide and how it's treated. And esophageal bleeding varices, these are very serious complications, very life-threatening if untreated, because patients can hemorrhage and go into shock and also die from it if it is not treated, because they will hemorrhage. So watching these patients closely if they are bleeding for hypovolemia and trying to correct their volume status and replete their volume is important. But we will talk more about that in depth as well.
That's for esophageal, you said?
Esophageal varices. Mhm. So for hepatic encephalopathy, there are 5 stages. First stage being the more mild version, which would be a patient having some confusion. They may have sleep disturbances. And then as stages progress, the symptoms progress, their mental status becomes worsened. And by stage 5, they're in a frank coma and they're completely unresponsive. So patients who are advanced in those higher stages of encephalopathy really need to be monitored for airway protection. They may require intubation if they're unable to protect their own airway. The cause, again, is because of the increased ammonia levels in the blood. And treatment to help get rid of ammonia is the lactulose. So lactulose helps to bind the ammonia in the bowels and excretes through stool. So typically what you look for is 2 to 3 soft stools from a patient who is on lactulose. And again, if they start to develop more frequent liquid loose bowel movement, that would be something to communicate to the provider. These patients should be, either restricted or have a low intake of protein because of the breakdown into ammonia. And also they should be avoided of any sedatives or tranquilizers because they're unable to metabolize those sort of medications. So they'll tend to hang around longer, which can cause them, again, to have a decreased level of consciousness. So nursing care for these patients would be monitoring for asterixis. So you see the hand flap there. So that is an involuntary flap. If you ask the patient to hold their arm out, it'll involuntary flap up and down. Also having fruity breath odor and lactulose should be given, and also educate the patients on the importance of lactulose. Because I don't know if you've ever had to give it before, but a lot of patients typically don't really like it because it's liquid, it's like syrupy, doesn't have the greatest taste. So sometimes you'll hear of students skipping their doses because they don't like it or they don't like to move their bowels. So importance of educating the patients on why they're taking lactulose. Also monitoring their mental status for any increased lethargy, monitoring their ammonia levels. Providing a safe environment for these patients is important. Oftentimes you may have like 3 side rails up for their protection, the bed lowest to the ground, a nice quiet environment, low stimulus. And then they're also at risk for aspiration as well if their mental status is not alert. Any questions about encephalopathy?
Why is there hand, by the pathology behind that?
I'm not 100% sure. Yeah, I just know it's a classic symptom of encephalopathy. So for ascites, This is when their abdomen has a rapid increase in girth. They may have a rapid increase in their weight because of all of the fluid accumulating in their abdomen. Patients will oftentimes be on a diuretic on spironolactone or aldactone to help rid of the extra fluid. They'll be on a low sodium diet, maintained on bed rest, and also undergo paracentesis. So paracentesis are not usually done initially. It's more therapeutic towards more moderate or severe ascites, just to relieve some of the pressure in the abdomen. Some patients can, have up to 20 liters of fluid in their abdomen. So that's a huge amount of fluid in that cavity. So it can be very uncomfortable. If you have ever had to assist with a paracentesis, you would want the patient to void prior, because if their bladder is full, there is a risk of perforation of the bladder when they, insert the needle into the abdomen. And oftentimes they're sitting upright if they're able to. Their blood pressure should be monitored closely because you're removing a lot of fluid from their abdomen, so there is a lot of fluid shifts. They could become hypotensive because they would be hypovolemic. So if that's the case, they would receive some IV fluid, some albumin, and try to correct the homeostasis of the blood. Also getting a weight before and after, and measuring abdominal girth that I've mentioned. A transjugular intrahepatic portosystemic shunt, or TIPS procedure, can also be done to the liver, which is where they put a stent between the hepatic vein and the portal vein, so that way it will help to decrease the portal pressure. Because if their portal pressure is high and they have portal hypertension, it's going to contribute even more to ascites. So that can help decrease the pressure within the liver. So nursing care for these patients, measuring abdominal girth, weighing them daily, noting what their abdomen looks like. They may have striae on their stomach, distended veins, they may have umbilical hernia. And also a classic symptom of ascites is a fluid wave. So if you were to tap one side of the abdomen, you would see the abdomen kind of like wave to the other side because of the fluid that's in there. And then monitoring for potential fluid and electrolyte imbalances is also important, especially when they're receiving diuretics, just monitoring all of their output. Does anybody have any questions about ascites? So esophageal bleeding varices. So this is extremely life-threatening. These patients will oftentimes be treated in intensive care units. This is when the large tortuous veins within the esophagus that have developed from the portal hypertension rupture or start bleeding, and they're going to have hematemesis. They may have some melena. They may be hemorrhaging, so you might end up seeing signs of shock. And what are your signs of shock that you'd be looking for? Clammy, yep. Tachycardia, hypotension, yep, pallor. Okay, so in these patients, the treatment would be to do an endoscopy to see what is happening there. One thing that is not mentioned on this slide is something called esophageal banding. So that is a procedure where you can go in with an endoscopy scope and find the varice that is bleeding, and you can put a little band around it so that it sort of clots off the bleed and stops the bleed. So not every single patient will lead up to this Synstake and Blakemore tube that I'm gonna talk about. So just know that banding is a possible treatment for esophageal bleeding varices. But there is always risk of rebleeding as well. One example that I had told to the morning class was that right now in the ICU that I work in, we've had a patient who has chronic alcohol abuse, severe cirrhosis, and he's been admitted for over a month in our ICU now with recurring esophageal varices bleeds and a huge ascites, probably one of the biggest bellies I've ever seen. So he's been banded multiple times. He's not a candidate for this Synstake and Blakemore tube, but he's been extremely critically ill through the whole process of going through his alcohol withdrawal, his variceal bleeding, dealing with paracentesis frequent blood transfusions. So these patients can be extremely sick and have the potential to go very wrong very quickly. So monitoring for shock and hypovolemia is very important. These patients oftentimes will be put on medication called vasopressin, which is a vasoconstrictor, and that helps to cease the bleeding. And also octreotide is another medication, which is a continuous infusion that patients may be on as well to help decrease bleeding. Propranolol is used more to prevent future bleeding, so it's not used as an acute treatment to their variceal bleed. It is used as a preventative measure for future bleeding. And the Synstake and Blakemore tube, this is a picture of it here. So it's a tube that goes all the way down in through the esophagus into the stomach, and the balloon helps to keep it in place in the stomach. And then there's a balloon here, the red that you can see within the esophagus, that is inflated to apply pressure to the esophagus where it is bleeding, where the varices are. So with this pressure here, you also want to be mindful for necrosis of the esophagus, because if there's a lot of pressure on the esophagus, it could cause the tissue to not be perfused. It could also even rupture an esophagus as well. So those are two major complications. And the third complication would be if a patient does not have an advanced airway in, such as an endotracheal tube at this time, this tube could potentially slide up and displace and end up blocking their airway. So it's always very important, as you can see here in the nursing care, to keep scissors at the bedside, because if their airway were to become obstructed, you would want to cut the tube to deflate those balloons as fast as possible. But again, yes.
What are those three biggest concerns you said?
So the three major concerns would be with this balloon here being inflated in the esophagus. If it's inflated too much, it could cause too much pressure on the esophagus, which would cause the tissue to possibly necrose because it's not being perfused. And it could also cause it to rupture. Again, pressure within the esophagus, if it has a weak wall, can rupture. And the third one would be if it were to displace and dislodge up into the throat, then it would occlude a patient's airway. So having scissors at the bedside is very important. Does anybody have any questions about variceal bleeds so far? Yeah.
Would they?
You said you do a banded possible treatment? What was that?
Banding, is that what you were saying?
Yes.
Yeah, so esophageal banding, so that would be where they go in with the scope into the esophagus and put basically like a rubber band around the bleeding varice to occlude the bleeding, so it helps to stop the bleeding.
Is it more or less like a hemorrhoid in your esophagus?
Yes, it is. It's a large tortuous enlarged vein or artery within the esophagus.
I have a question, another one.
Mm-hmm.
Since you give propranolol, you said you give it for bleeding, but if the person goes in shock, you give it propranolol, wouldn't that
So-
decrease the
So
heart rate?
propranolol is not used in an acute hemorrhaging bleed. Propranolol would be given to prevent future bleedings. So patients may be on this at home to help prevent future bleeds. So the Senstake-Blakemore tube is just a temporary measure, usually less than 12 hours. It will stay in place. And then the medications are, as I mentioned, octreotide, vasopressin, propranolol for future bleeds, and ICU level of care. So the main goal of these patients would be to replete the volume that is lost if they're having large amounts of hemorrhage. So these patients will require a lot of transfusions potentially, whether it be packed red blood cells or fresh frozen plasma for volume expanders, and also some IV fluids. Any other questions about this one? Mm-hmm.
Just that last thing. So that right there is just a surgical procedure? Is that what that's supposed to be?
So it's not a surgical procedure, it's just like placed down the esophagus, almost like a oral gastric tube would be.
But that's not what's called bending, no?
No,
Okay.
banding is separate.
So, excuse me.
Yeah.
So when did they doing the banding? In this
So
situation?
banding would be if it's not as severe of a bleed, if it's a more stable patient. And a patient who is hemorrhaging, going towards shock, they get the same Senstake-Blakemore tube.
You said it's temporary,
Mm-hmm.
so after 12 hours, what if after 12 hours there's a rule, can we reinitiate it after 12 hours or it continues?
You know, I haven't heard of that being replaced again. Yeah, I haven't heard of it having to be like replaced.
Did you
I
say
know.
But the banding you can do.
Yes, yeah, because it's separate, small little bands that go around each area that is bleeding.
So, would they be throwing up blood or would they be,
Yes, Melanie?
yeah,
Is that, yeah,
Like-
so, yeah, they will be throwing up blood, bright red blood, hematemesis, and they can also have melena. Because an upper GI bleed, it'll turn into melena as
okay,
it goes down through the GI tract. It'll look like older blood.
right, okay, thanks.
Okay, so medications, just to recap, propranolol is your beta-adrenergic blocker, and it's used in prevention of variceal bleeds. Spironolactone is the diuretic that's potassium sparing that will be used for patients with ascites. Octreotide is the growth hormone which helps to decrease bleeding in variceal bleeds, as well as vasopressin. That's not written there, but you can write it below that. That's the vasoconstrictor. That's also oftentimes hand in hand with octreotide in a massive bleed.
What was that again? I'm sorry.
Vasopressin. And it was on the previous page too. Lactulose, which is your laxative to help get rid of excess ammonia for hepatic encephalopathy. And then your vitamins, folic acid and vitamin K will help with your clotting factors.
And I remember you mentioned albumin, you said that was for the ascites?
Yes. Mm-hmm. So overall, with a cirrhotic patient, nursing care would just be promoting rest, maintaining their safety, especially if they have any sort of change in mental status or decreased LOC, aspiration precautions, increasing their nutrition, ensuring that they're getting their vitamins and that they understand the importance of taking their vitamins, providing skin care, And also monitoring for complications, which would be like your spontaneous bacterial peritonitis, bleeding varices. Okay. Does anybody have any other questions about cirrhosis before we move on to hepatitis? Okay. So hepatitis can be either viral or non-viral.